My name is Minali Nigam, and I am a headache fellow at the Graham Headache Center in Boston, affiliated with Mass General Brigham and Harvard Medical School. I'm really excited to talk today about stroke and migraine. What's the link? I don't have any disclosures. I have four main objectives for today's talk. So, one is to talk about the definitions and mechanisms of migraines and strokes and overlap between the two. The second is to understand some risk factors and prevention strategies. And then I'll review three clinical cases that address the stroke and migraine connection. And then lastly, I'll talk about some treatment options that we consider when we think about both conditions together. So going back to the basics, what is a stroke? So essentially, a stroke is a neurologic condition that's caused by decreased blood flow to the brain. So the brain cells need nutrition that's supplied through the bloodstream. And when we have a lack of blood flow to the brain, those brain cells essentially lose that nutrition and either get injured or they can die. And essentially, once the brain cell function is lost, that can lead to neurologic deficits like trouble speaking or weakness, numbness, difficulty seeing. And so we have two main types of strokes. So one is called an ischemic stroke, and another is a hemorrhagic stroke. And so with hemorrhagic stroke, this is really when we think about brain bleeds. The majority of this talk is going to focus on ischemic stroke because that's where we have more evidence and data in terms of migraine correlation and risk factors for ischemic stroke. The evidence really isn't strong for migraine correlation with hemorrhagic strokes. This is just a really quick mnemonic that I like to tell people called ACT FAST. This is a mnemonic that's used to recognize stroke symptoms. So facial droop, arm weakness, speech difficulty. Recognizing the possible symptoms of a stroke is really important because some of the interventions we do, like clot busting medications or a procedure called a thrombectomy, where we can go in and remove a clot, are really time sensitive. So there's very strict parameters and time windows where patients can be eligible for these interventions. So if there's ever a suspicion for a stroke, need to go to the ED, acute care setting right away to get evaluated. So what's a migraine? So migraine is a type of headache. We use the International Classification of Headache Disorders in the headache community to categorize different headache types. So for migraine, the ICHD-3 categorize it as a headache that lasts between 4 to 72 hours. There are various characteristics that are in the criteria, though these are definitely by no means all encompassing, but these include things like being unilateral, so one-sided, pulsating pain, moderate to severe pain levels, and aggravated by physical exercise. There's also several features that accompany migraines: nausea, vomiting, light sensitivity, sound sensitivity. Some people do have smell sensitivity, vertigo, but some of those other features are not part of the criteria in ICHD-3. Then there's also migraine with aura. So what is an aura? Essentially, it's a reversible neurologic deficit. Usually an aura lasts between 5 minutes to 60 minutes, and usually a headache follows the aura. Visual aura is the most kind of aura, though there are other aura types that include things like numbness, weakness on one side, speech difficulty, etc. So when we take the definition of migraine, aura, and stroke symptoms, how do we distinguish the two? It can be tricky. So there's a condition called transient ischemic attack. Sometimes people call it a mini stroke, but essentially a TIA is when there's stroke symptoms that happen for a short period of time, usually less than an hour, but it's the same mechanism as a stroke. And so we treat it as we would preventatively for strokes. So distinguishing between migraine, aura, and TIA symptoms can be challenging, but there are a few characteristics that we use to try to distinguish the two. So one is that migraine visual auras tend to be positive in nature. So these are things like floaters, flashes of lights, different colors, kaleidoscope vision, some patients have described to me, whereas the TIA visual symptoms tend to be vision loss. So whenever there's vision loss component, we definitely would want to get like a stroke workup. Migraine aura tends to be gradual, whereas stroke symptoms tend to be very sudden onset, abrupt, happen all together. The symptoms in migraine tend to be more progressive. So get one symptom at a time as opposed to everything coming at once. And migraine auras tend to be pretty repetitive in nature. And like I mentioned before, a headache usually follows migraine aura. Headache is not a typical feature of an ischemic stroke or a TIA. For hemorrhagic stroke and brain bleeds, you can see headaches, but not as much with TIAs and ischemic strokes. So why should we even care about the link between migraine and stroke? So both conditions are very prevalent in the population. So when we take migraine, for example, it's the number one cause of disability in folks under the age of 50. There's about 1 billion people in the world who suffer from migraines. There is a female predominance in terms of who gets migraines. As you can see from the yellow curve, there does tend to be a high prevalence of migraines sort of between the age of mid-20s, mid-50s, and then beyond. There is a downward trajectory, possibly related to menopause and changes in hormone after a certain age group. And then with strokes, so why should we care about strokes? So it's the number 2 cause of death worldwide, just behind heart attacks. And it's the leading neurologic cause of disability. There's also a disproportionate outcomes when we think about mortality and morbidity, especially folks who identify as people of color and those who are part of the lower socioeconomic class. So there's a huge prevalence of both migraines and strokes, and we do often see patients who have both conditions. And so let's get into the nitty gritty and the biological basis, in terms of mechanism of migraines, and then I'll talk about strokes in a minute. So the underlying mechanism of migraines is pretty complicated. So I'm going to break it down in as simple terms as I can. But essentially, there's a prodrome phase of a migraine. So this is before even the headache part of the migraine comes on. And we think that the basis of the migraine activation path starts with 2 different structures in the brain. So there's the hypothalamus, or the part of the brain that regulates water and temperature of the body. Then there's the brainstem. The brainstem is involved with all kinds of different functions, including consciousness, ability to talk, walk, strength, sensation. But we think that there's some activation that happens in the hypothalamus or brainstem that triggers these cascade of events. So the first one is something called cortical spreading depression. And this is a phenomenon that's closely related to migraine aura. And essentially what happens is that there's electrolyte imbalances or ion imbalances between sodium, potassium, calcium channels. And as a result of those ion imbalances, the nerve cell or the brain cell essentially gets depolarized. And so during that period of time, there's high metabolic activity going on. So initially, the blood vessels in the brain dilate. There's more blood supply going to those cells. But after a couple of minutes, there's then a period of time, about a couple of hours, where there's actually decreased blood flow. So that's a phenomenon called oligemia. And it's during that time of decreased blood flow to those cells is when we can see aura symptoms like temporary vision symptoms or numbness, tingling, or weakness, etc. So cortical spreading depression and aura, we think, is the underlying mechanism of aura. And then further down the migraine cascade, there's activation of the trigeminal vascular system, which is within the brainstem itself. But once that area is activated, there's then a release of different inflammatory markers, proteins, peptides like CGRP and PACAP. Both of these proteins are actually target sites for some of the newer migraine therapies that we have on the market. And then after the inflammatory cascade, there's this activation of deeper structures in the brain and within the cortex or the surface of the brain that then convey the pain signals that we see in the migraine, the headache part of the migraine. So thinking about mechanisms of strokes, there's several different mechanisms at play here. So there's decreased blood flow, but that can happen through clot, through blockages, through tears. So there's different kinds of clots that can build up and cause an ischemic stroke. So one is just plaque buildup over time. So that's the atherosclerosis. There can be an embolic stroke, and the embolism can come from different sources. So sometimes it's the heart. There could be a thrombus or clot in the heart that then travels to the brain. There can be an abnormal heart rhythm called AFib, which can make people have a higher likelihood of clot development. Endocarditis, which is a type of infection. All of these things can be the sources of clots. Cancer can be another source of clot. There's also a condition called patent foramen So usually the PFO is closed after birth, but some people do have an opening in among the two chambers of the heart, and that's called patent foramen ovale. And so if there's this opening between the two chambers, there's basically communication between the left and right side of the heart. And so if there is an embolus anywhere, that could potentially travel through the hole and then travel up to the blood vessels into the brain and cause a stroke. This is an important mechanism when we think about folks who have migraine with aura and stroke. Then there's other mechanisms like a dissection, which is a tear in the blood vessel that can lead to decreased blood flow to the brain. Then there's smaller blood vessels within the brain that over time can get hard and stiff as a result of high blood pressure or diabetes. And so that stiffness can eventually lead to decreased blood flow and ultimately a stroke. So there's several different mechanisms at play in terms of what can cause strokes. So how do we combine the mechanisms of the two? Okay, so I already talked about cortical spreading depression and what that entails. And there is that short period of time where there's a lot of metabolic activity and increased blood flow, but then there's a period of time where there's decreased blood flow. And it's that decreased blood flow where we can see migraine aura symptoms. Now, that alone is not enough to cause a stroke or a TIA. There has to be some sort of additional insult. So this can be things like genetic conditions, if there's abnormal blood vessels, if there happens to be a microemboli or a clot that's already circulating at the time of the cortical spreading depression. That double insult is when we think about symptoms of TIA or stroke. And typically, this would be in the form of a migrainous stroke, which I'll talk about in a minute. Now, this is what we think. We theorize. None of this has been proven 100%, but this is just based on animal models and current studies that we have so far. We think this is sort of the underlying pathophysiology of how there could be a stroke during a migraine attack. And so talking about a migrainous stroke, migrainous infarct, this is a stroke that happens during the time of a migraine attack. There's different mechanisms through which this can happen. I explained sort of that decreased blood flow, oligemia, but usually there has to be that second insult. It can be related to a supply-demand mismatch. It can be related to genetic symptoms. It could just be related to clotting factors that are impaired in certain patients who have migraines. So there's various different mechanisms. The exact definition is essentially a stroke that happens during a migraine attack that resembles what someone's typical aura looks like, except that the aura is a lot longer. So I mentioned that usually auras tend to be between like 5 to 16 minutes, but if auras are lasting much longer than what is typical, then we would worry about something more ischemic going on. And so that's when I would be worried about a stroke specifically. There are, of course, strokes that can happen outside of the migraine attack. They can also happen through a variety of mechanisms that I talked about before. We will talk a little bit more along in the talk about migraine abortive medications, specifically triptans and their risk associated with stroke. Okay, so what are the risk factors more generally in patients who have strokes? So patients who have high blood pressure, high cholesterol, diabetes, who are smokers, all of these, can put patients at risk for stroke, and all of these, can be modified through lifestyle changes. When we think about the migraine population, typically the ones that are bolded, high cholesterol and smoking, tend to have higher prevalence in those migraine patients who also have stroke. But when we think about the characteristics of migraines themselves, there's a few variations that can put patients at higher stroke risk. So patients who have migraine with aura are 2 times higher in their stroke risk compared to patients who are of the general population who don't have migraine with aura. So aura puts someone at higher stroke risk, higher migraine frequency, later onset of aura. Those are all sort of risk factors that we think about in terms of higher stroke risk. Patients who just have regular migraines as well are at a slightly higher risk, not as high as those who have the aura component, but in terms of mechanisms for how patients with migraine can also get stroke, it's the common stroke factors that include things like plaque buildup. There's been some studies that have also shown arterial dissections, the tears in the vessels that can also lead to strokes. In terms of migraine with aura, so there's a few different mechanisms. One is the patent foramen ovale. So that was the opening between the two chambers of the heart. That's actually been shown to have a higher prevalence in migraine with aura. We're not exactly sure why, but that is a common mechanism of stroke. We don't recommend premature closure of a PFO in migraine with aura. It's only after stroke burden do we actually close the opening. AFib or the abnormal heart rhythm is another mechanism that we see. And sometimes we just don't know the cause of the stroke in folks who have migraine with aura. So I'm going to review a couple of cases. So the first case is a 20-year-old female who comes into the clinic. Her typical aura includes visual floaters, usually lasts about 5 minutes, and then she has a right-sided headache. These have been increasing in frequency to about once a week, and she's also on oral combined contraceptive. Her pill includes both progesterone and estrogen. So what would next steps be, and how would I counsel this patient in the clinic? So there's a few key things to recognize in this. So young patients, stroke is much more rare in young patients compared to older patients. However, there is 10% of ischemic strokes that are found in young patients, and many of those patients do have migraine. And there has been independent association between stroke and migraine in the young. So when we think about stroke risk, someone who is on a combined hormonal contraceptive, someone who doesn't even have any history of migraine, they're already at a higher risk of having a stroke compared to someone who isn't on hormonal contraception. So they're about 2.5 times higher stroke risk. You add migraine without aura, that's 4 times higher stroke risk. Now add migraine with aura, that's 6 times higher stroke risk, and now add smoking history with the migraine aura, and you're at a 10 times higher stroke risk compared to the general population. And so generally, patients who have migraine with aura, we counsel them to come off of the combined hormonal contraceptive. If they absolutely have to be on it, then best is low-dose continuous estrogen. Progesterone-only pill is also an option. The second case, so this is a 5-year-old female who has multiple family members with migraines and strokes. She does have known migraines with aura. Her aura is left-sided numbness. She gets this brain MRI, which shows extensive white matter disease, which is essentially scarring of brain tissue that can happen over time with blood pressure, diabetes. We can also see this separately with patients who have migraines. And she comes to the office with elevated blood pressure. So what are some next steps? So the condition that I would be thinking about for a patient like this, who's had multiple family members with migraines and strokes, and who has this degree of white matter disease, this would prompt me to think about a condition called CADASIL. And so usually we confirm this diagnosis with genetic testing. Notch3 is a mutation that affects the smooth cells in blood vessels. And some of those blood vessels are the small vessels that can be in the brain. So if there is this mutation, then those blood vessels can become stiff and be at a higher likelihood to lead to a small vessel stroke. And so I'd want to get that genetic testing. I would definitely want to work with this person's primary care provider to monitor blood pressure. And I would probably start this patient on a migraine prevention that also addresses blood pressure as well. The third case, so this is a 50-year-old gentleman who comes in with migraine, has visual aura, is on propranolol and sumatriptan. But instead of his usual 5-minute aura, he's coming into clinic with an aura that's lasting pretty long. It's been over 6 hours now. And so what would be the next step here? So I would worry about this patient having a migrainous stroke. So his aura is lasting much longer than usual. So I would want to rule out any kind of stroke burden. And so I would refer this patient to the ED to get stroke workup with a CAT scan, getting blood work, getting a cardiac workup. And like I said, time is brain. So, some of these interventions that we do, like clot busting medications or thrombectomy, the surgery to remove the clot, those have very specific time windows. With the clot busting medication being within 4.5 hours of initial symptom presentation, and then thrombectomy being within 24 hours of symptoms. So they're really, time locked. So getting to acute care as quickly as possible to get the stroke workup. And then if there is imaging that's suggestive of stroke, initiating antiplatelet or some sort of blood thinner as preventive, depending on how big the stroke burden is and if they fit the time window for these other acute interventions. Thinking more long-term, I would definitely stop the sumatriptan. Triptans are contraindications for patients who have stroke. And I would try to switch to a different abortive medication. So let's talk about the triptans. So how do they work and what exactly is their deal with stroke risk? So triptans work by acting on serotonin receptors, and essentially they act like proxies or agonists of serotonin. And so serotonin agonists can cause vasoconstriction. Typically, when we think about strokes and vasoconstriction, those are intracranial vessels, so inside the brain. Extracranial is outside the brain. Typically, triptans tend to act extracranially, not intracranially. So some of my patients have come to me saying, their providers have counseled them not to take triptan during an aura. So even patients who don't have stroke history, are being counseled that, there's an increased risk of stroke and vasoconstriction if you take a triptan during the aura. This is theoretical, it's not proven in the literature. So I typically tell patients that as soon as you get the aura, you can take the triptan, you can take the abortive to try to prevent the migraine from escalating into that full-blown headache. So this is just based on the evidence that we have. There's really not that increased vasoconstrictive stroke risk if you were to take a triptan during an aura. Serious cardiovascular risks for triptans are rare. So for patients who don't have a stroke history, there's really been only one study that's shown a clear association with stroke. Generally speaking, though, patients who have already had a stroke or a heart attack, it's currently listed in the guidelines as a contraindication. So most providers will avoid the use of triptans in patients who have strokes. Though I will say this is a bit of a hot topic in the headache field. Some providers will allow for it on a case-by-case basis, depending on the stroke size, the stroke disability, how responsive a patient is to a medication. So, these decisions are made on a case-by-case basis, but just as a rule of thumb, most providers generally avoid triptans in patients who've had or have strokes. What are other treatment options we can think about? So in addition to trying to avoid triptans, there's other vasoconstrictive rescue medications like the ergotamines that we try to avoid for similar reasons as triptans. But other treatment we can think about, so in terms of blood thinners that can prevent future strokes from happening, there's aspirin, clopidogrel, which interestingly enough, clopidogrel has been shown in some studies to reduce migraine attacks as well, in addition to being a stroke preventive. Lasmiditan also works on serotonin receptors and acts as an agonist similar to the triptans, but it doesn't work on the receptors that cause vasoconstriction. So they are safe to give in stroke patients. The CGRP antagonist, so that was one of those inflammatory peptides that are released during the mechanism of migraine. We can use those in stroke patients. And I really want to highlight this next point, which are some of the blood pressure medications. So in patients who have risk factors for stroke, blood pressure is one of them. And so if we can kill two birds with one stone, I like to do that. So a lot of these antihypertensives can also be used for migraine prevention. So beta blockers like propranolol, calcium channel channel blockers like verapamil, ACE inhibitors like lisinopril, candesartan is an ARB. So there's a lot of medications that can have a dual effect almost, so lowering blood pressure and have a migraine preventive. And I do like to think about these as options for patients who have both strokes and migraines. There are other safe options for patients who have stroke and they need migraine prevention. Those include things like Depakote, Botox, melatonin, and acupuncture has also been demonstrated to be safe in some studies. Okay, so to summarize, patients who have migraine with aura do have increased stroke risk by about twofold compared to the general population. Migraine and stroke share several risk factors and may have some overlap in pathophysiology and mechanism. We talked about cortical spreading depression and a second insult. And then, there's prevention strategies that we can use, including lifestyle modifications that can help for both stroke and migraine. We try to avoid combined hormonal contraceptives for patients who have aura, and blood pressure monitoring is crucial for patients who are have a stroke risk. And then in terms of treatment, trying to avoid medications that have contraindications, and using medications that could potentially reduce the risk for both migraine and stroke.